Hello? Dr. Kanaki?
Can you hear me now? Is my microphone back up?
Yes, I can.
Okay, great. Thanks for the introduction, Joanna.
All right. I'm just going to run through a quick things. We're going to go through the participant guidelines. All telephone lines has been placed on mute. Today's sessions is being recorded and will be available upon request. Questions will be answered during the presentation and during a QA period at the end of the session. Please use the chat box to send us your questions and make any comments. We're going to be displaying QR codes throughout the presentation, which you can use for reference and further information. All you have to do is open your smartphone's camera and try to take a picture of the QR code, and it will take you straight to the reference and the resource. The goal of SIBA for health equity is to build capacity of leaders and staff within community-based care settings to identify and address health inequities at the organization and community-wide levels. Our official program hashtag is hashtag Proceed SIBA for Equity. You can find us on all the social media presented here. So let's get started by getting to know each other, and I'm going to roll a few poll questions for you to answer. So the first question is, in which region of the United States is your organization located? Please take a few seconds to answer. All right, I'm going to close the polls in 2 seconds. All right, so today we have a very wide range of assistants. We have 36% of people from the South and the Northeast. We have some representatives from the Caribbean, the Midwest, and the West as well. So everybody, welcome. Our second question, we would like to know what type of organization do you represent? So please choose out of the following which one is the best that represents your organization. I will give you a few seconds as well. All right, 3 more seconds to answer. All right, let's see. So again, a wide range of organizations. We have 43% from government agencies, either local, state, or federal, 34% from community-based organizations, 12% from others, and then we have 3% for healthcare clinics or federally qualified healthcare, and 9% from hospital or medical groups practices. We'll also see some people in the chat commenting. We have some people from extension services, university, and academic institutions. So welcome. And then our last question before we give the microphone to Dr. Kanaki is, which of these groups best describe your position within your organization? Between leadership, mid-management, and then frontline clinical and non-clinical, and then others. All right, a few more seconds. All right, we have 80% of votes. So let's see the results. All right, we have 45% mid-management, coordinators, consultants, specialists, and educators, 23% leadership, director, management, chairs, and supervisors, a 13% non-clinical frontline, 10% frontline, and 9% other. And then among the other, we have some clinical and some professors as well from research. All right. So the objectives for today are to review important terminology to understand testing and COVID-19. We're going to explain the basics of COVID-19 as it relates to its epidemiology and clinical diagnosis. We're going to discuss the different types of COVID-19 testing currently available in the US and throughout the world, as well as discussing some treatments and potential cure options for this pandemic. We're finally going to describe the current testing availability issues and the impact on specific populations as it relates to health equity and social determinants of health. Today's agenda will go as shown here. We are going to cover basics, test availability, treatment, cures, and text accessibility for some populations. We're also going to be having some Q&A sessions throughout the presentation and a larger one at the end. So don't wait until the end to ask your questions. I will be managing that and asking the questions to Dr. Kanaki. All right, so before we get officially started, we're going to start with one last poll question to introduce the topic for today. So, true or false, the current coronavirus pandemic is the same or less of a problem than a bad year of seasonal influenza? I apologize if my slides are not advancing fast enough. My computer, my internet is having a little bit of issues. We're having a big storm over here, so they might be going a little bit slow. All right, so we have over 85% of votes. So let's close the poll. And Dr. Kanaki, before you start explaining the answer, 95% said that this was false and 5% said that this is true. So the microphone is all yours.
Okay, I'm glad that those numbers came in the way they did. It makes me very happy to start that way. So the slides aren't advancing for me either, Joanna. So I'll just address the poll question. Maybe you can get them caught up for me.
All right, where are you seeing him?
I'm still stuck at the title card.
Oh my goodness, okay.
While you figure that out, I'll talk about the poll question. So it seems we have an interesting cross-section of people at this lecture today, mostly in the South and East Coast, mostly government agency, federal level, and a lot of leadership and mid-management. So what's important for today's talk is probably going to be a lot of data, a lot of metrics, a lot of deliverables. And with the first poll question, I just wanted to bring to the attention a little bit of viral biology. Obviously, we have flu spikes every couple of years around flu season. We track those mutations and we tailor our vaccines to them. Our vaccine rate isn't the best, but that's what we're at right now with the snapshot. As far as coronavirus, it's just a common cold virus that has mutated quite specifically to be pretty aggressive for this season. So regardless of what interventions we're taking, it's actually a much more aggressive clinical picture. And that was the point of that question. So I'm glad everybody is pretty much on the same page there. Joanna, it looks like it's caught up. You're at the how did we get here slide.
All right, should I go next then?
Yeah. So how did we get here? Basically, a timeline of events happened since November of 2019. First patient in Wuhan, China was suspected to catch this virus from wet market conditions where viral mutations occurred, and I'll go into that in more detail. Since then, it's just been epidemiology as usual as pandemics go, and it's grown exponentially since then. It's been redefined by major organizations like the WHO into a pandemic properly. Our first case in the United States was late January. As cases grow, our system has been taxed, our deliverables have been limited. We're going to talk about some testing concerns today. And as cases rise, we have shortages and highlights for different sections of the population that we have to address. So let me see if I have control of the mouse. I think I do. I think I might not. Did the slide change for you? Okay. So here's a CDC report, representation by Epidemiology Week, just a cumulative report since January to a few weeks ago, 1.5 weeks ago. Joanna mentioned that I like to use QR codes in my talks. I think it's a good clutter-free way for everybody to just take a pause. And if you're interested in something specific, go ahead and scan it with a smartphone camera. It'll show up on as a link. You can go straight to it and look at this report. This one, for example, is from the CDC. You can see here an obvious exponential increase in cases, but this is just tracking at its core. Next slide, if you please. Okay, so when I talk about how we got here and I talk about data, metrics, and deliverables to the folks that kind of checked in the poll of cross-section in the audience, there is a lot to talk about as far as epidemiology and public health. And organizations like the CDC, WHO, and others have put together basically models for the way we track and report cases. This is a convoluted, nice flow chart. It's confusing, it's intimidating. You don't need to worry about it. You can scan it if you're interested, but they've released a WHO report that discusses how we do trace tracking, basically from patient 0 and down. And this informs our clinical decision-making as far as where to put tests. This is going to come up a little bit later in the talk. The funnel on the right is actually something I like to see very much, where first few cases, FFX is a metric we can use while we're doing case tracking to track down some of the stuff and inform our testing resources and where to put them. There's going to be some guidelines I'll show you from the CDC and the US Preventive Task Force that have more details on that. Cool, I think I have the mouse again. It's 50-50 shot, I don't know. Okay, can't talk about epidemiology without talking about a reproductive number, or an R-naught. The R-naught estimate, based on lots of studies, is somewhere between 1 and 4. I'm being conservative here. It's being studied now, data is coming in now. Basically what that means, if you didn't already know, is that if one person has this virus, they will transmit it to 2 people on average, and those 2 people to another 2, to another 2, as we go down the exponential pyramid. Compare it to some viruses we know from recent history. Zika was about 3 to 6. Ebola was 2. Measles is pretty dang high. So every virus has its own reproductive number. What does this do? It informs us about the severity of a pandemic, but it also informs us of how quickly we have to move. You know, I'd say our value of 2 is pretty significant. We should probably address this as clinicians on my end pretty seriously. Let's go next. Okay. Now, if you haven't used the Johns Hopkins dashboard for background information, this is your chance. If you scan that QR code there, it's going to take you to a website that Hopkins provides up-to-date information on global cases, as well as US cases, total deaths, confirmed cases, and total recoveries. They incorporate a lot of different article journals for data. They track in real time. This gets updated daily. You can watch it as a living, breathing kind of diagram in the background of your computer screen. It's a really important tool for supply chain, resource management, public health, government officials, local public health, to watch this progress as it goes throughout a country or state, especially when we start to consider social distancing, which we'll talk about. So next. So before I get into the nitty-gritty, I want to get on the same page first as far as some vocabulary. Joanna, do you want to run a poll question first or after this?
Yep, I'll go ahead and run it right now.
Cool.
All right, so our next poll question is the number of COVID-19 cases or deaths should decrease as we approach warmer weather. Is this true or false? All right, I'm going to give a few more seconds to reach above 80%. All right, I'm going to close now. So, Dr. Kanaki,
Nice.
we have 60% of people said this is false and 40% said that this is true.
This is a pretty close one then. Okay, this is great. If
Right.
you notice on the Johns Hopkins map, there were plenty of cases that are in traditionally warm weather climates. I know we have some folks from the Southeast watching. Florida is one of the states you'll see in the news sometimes as far as whether or not we can restart business and open and go back to usual. There are still cases in places where it's warm. So the expectation that seasonal change is going to affect this really isn't in the data yet. I can't say that with 100% confidence because nothing in medicine is 100%. That being said, it looks like this virus doesn't care what season it is. So basically that answer is false. As the weather continues to progress into the spring and summer, we're still going to see cases so long as we have people within infectious range of each other. So excellent breakdown there. Okay, so I want to get on the same page with everybody because I'm going to talk a little bit about virology, just to give everybody a brief primer. I know we've got all kinds of different backgrounds here. So COVID-19 is the actual name of the disease you get. And it's just called COVID-19 because it originated in China, it's a virus, and we found it in 2019. Very simple. That's not actually the name of the virus, though. The virus is called SARS-CoV-2, which is basically a sequel to SARS, if you remember another outbreak in recent history of severe acute respiratory syndrome. It's a cousin of that virus. It's a cousin of the MERS virus. Again, these are coronaviruses that cause the common cold that have mutated to be more aggressive than normal. A virus is just a collection of proteins and lipids that has auto-function programming to just make copies of itself inside of a host where it invades cells, duplicates, and mutates. Replicating is basically a virus hijacking normal cells. Receptors are where they recognize how to go into different places in the body and cells. And I keep talking about these viral mutations. A lot of this is a small piece of genetic code viruses carry around with them, and every time they infect something, they steal a little bit of that DNA to rearrange new ways, and that random mutation sometimes ends up being a very severe viral infection. Most of the time, virtually a majority of the time, it actually hinders their reproductive rate. So these are random mutations that happen because of exposure conditions. And this disease is definitely an inflammatory one, which causes a lot of things to happen throughout the body, which I will show you. All right, next slide. I think I clicked it. Okay, so a zoonotic virus. That means this virus originated in animals first and then mutated to go into humans. This is not uncommon, but it's not rare. It depends on the conditions that these viruses are kept in. I mentioned the wet markets of China. They're called that because livestock and different animals are bought and sold for slaughter meat or whatever reason. And they're kept in these close quarters, and a lot of spillage happens in body fluids and things mix between animals, like in this case, bats and pangolins. And they were handled by a human who accidentally was introduced with this virus or viral particle, and it attached to human-specific receptors, changed into a human virus, and this is how we have an outbreak. You can see here these receptors in red. They're the ones that recognize particular receptors, especially in our lungs, which is why this was designated a severe respiratory disease. One more back, sorry. So severe respiratory disease starts with discussing pneumonia, okay? There are viral pneumonias and bacterial pneumonias and other pneumonias, but let's just talk about viral. So basically the virus goes inside our lungs, infects cells that live in the linings of our lungs, and makes it very difficult for us to breathe. That's why you see so many patients on ventilators having problems breathing. But how does this disease go from a flu-like symptom to so many death and dead patients and cases all around the world? Well, I mentioned it was very, aggressive inflammatory disease, right? So that first step of getting a virus inside your body is called inoculation. Some people think it's fecal oral, which means, hand washing concerns. Most people think it's droplet. There's no proof that it's airborne yet, but it does live on surfaces for a little while, like a lot of viruses do. Our immune system responds to this like anything else. And when it does this, we get a fever, we release a lot of extra white cells, a lot of extra proteins that act to protect us. Those proteins obviously have damaging effects downstream. So it may start in the lungs, but it may go to the gut, the liver, the kidneys, and all of a sudden you've got flu-like symptoms, then pneumonia, then severe respiratory disease, shock, multi-system organ failure, and then now you have a death certificate that says COVID-19. But how does that start? So this is a little diagram which is very heavy right now. We're going to come back to it, but for the purpose of this end of the talk, just watch a virus attaching, going into a cell, probably in the lung, replicating using enzymes, and then re-releasing copies of itself that go all throughout the body. The things in squares, they're going to be targets for potential therapies, which we'll discuss towards the end of this talk. So just bookmark this in your mind for now.
Thank you, Dr. Kanaki. So now we're going to make a very quick pause and ask some frequently asked questions that we received before our webinar. So the first one is, what made this virus mutate so aggressively that affects humans the way it does? How many strands of this virus do we know of?
Sure, you got it. So a virus's primary job is to mutate. That's the way they work. They infect some cell in an animal or human, they rearrange DNA and hope for the best, which for them is to make us sick. That happens all the time. And like I said, virtually it never ends up with anything serious, but sometimes it does. And we're watching that happen now. As far as strands, this is just a coronavirus. It's one of the simple common cold viruses. There are about 8 strands. I mentioned some of their cousins in previous outbreaks of this specific coronavirus pandemic. This time, there's 3 strands, but they're not very different from each other, so we can just treat them all the same.
Great. Our next question is there any evidence that this virus was man-made instead of naturally occurring?
This is a very good question. A little bit of a conspiracy theory question, but I like it because a lot of people have been asking me this, and it's a good topic. There are, laboratories that operate at high biosafety levels that work with viruses for research, for vaccines, for protection, et cetera. But we don't have, I'm sorry, there's a second half. We don't really have a history of being able to create a virus from scratch. So the fact that you can see the DNA from the different animals it's infected is the living proof that it didn't come from a lab. Go ahead, sorry.
Oh, thank you, that's great. Our last question is, why is the cause of death reported to be COVID-19 when people are dying from their underlying or pre-existing conditions?
Excellent question. So pre-existing conditions are a very specific subset of people we worry about during this pandemic, right? Especially those with, lung issues and blood pressure issues and things that are related to the specific targets of the virus. Like with anything, you don't always die of your pre-existing condition. You just have a weaker immune system, and maybe something puts you over the edge, like a virus. And this is important because this is reportable data for public health tracking.
Great. I have 2 questions quick from the chat box. We have Tessa, that is, as we back up a couple of slides, did you say COVID-19 strands for Chinese originated viral infection disease discovered in 2019?
That's correct. The entity or the disease we diagnosed this as was actually first found in China in the Wuhan province in 2019, I believe in November.
All right. And Ronnie Mills is asking, can an individual be reinfected or have a reemergence?
This is a good question too. We're seeing a lot of negative tests, positive tests, recurrent tests. You can get a common cold more than once, right? And this is a cousin of the common cold. So it's really too early to tell if people are getting reinfected. I wouldn't put it beyond the scope of possibility, but it's not something that frontline clinicians are really worried about right now. We're just trying to get out of the thickest part of this problem.
Great. All right, that's it for right now. Keep sending your questions. We'll be reading on the next pause.
Yep, they were great. Okay, so COVID is a clinical diagnosis. It happens so fast that we don't really have time to test for it, first of all, nor do we actually have tests when this first started. You don't have to worry about this slide too much. This is just an intensive physician's take on it on the West Coast when it started in Seattle. And he talks about a little bit of epidemiology, a little bit of the biology I did, some information at the bedside, and what we can do to sort of address it both in the hospital and outside. It's very useful stuff. 1 second, let me click. Okay, so I mentioned this causes problems in the lungs, right? In the top left, you'll see normal lung tissue, right? Nice little pockets, oops. Nice little pockets of air that get filled and then transfer themselves into our bloodstream so we can have oxygen. The bottom slide underneath that shows diffuse alveolar damage. Those little air pockets are alveoli, and in some diseases, they get damaged like in pneumonia. With COVID, you have something called acute respiratory distress syndrome, that these air pockets actually fill very quickly and have this protein debris that acts pretty much like a wall, so no air can get through. And that's how you get these serious downstream effects. Okay, now let's go to the next slide. Thank you. So I mentioned earlier, we have to sort of triage who we test because of resource limitations and supply chain problems. The US Public Health Service and the CDC put out this 4-tiered model of who to test first, when, and how. And it basically starts with frontline workers with signs and symptoms, then high-risk patients and first responders, then essential employees, all down the list. And we don't really test non-symptomatic people yet. We're not at that stage yet because we're triaging. Next slide. Okay, Joanna, do you have a poll here, or do you want me to just go over the vocabulary that I have?
You can continue.
Okay, thank you. So I'm going to talk about testing just for a little bit to get everybody up to speed. There are 2 types of tests, okay? Molecular testing and serology testing. Molecular testing looks for small amounts of DNA from the virus that can show us whether it's there or not. We use things like primers to amplify copies of DNA to make sure that we have it or don't. Serology testing is based on our own immune response, creating these little proteins that are called antibodies, which we use to protect ourselves against infections. And I'll show you a picture of this soon. Next slide. Okay. So these 2 tests, like I said, molecular testing and serology testing. The image on the right is what most of these tests are. You get a nasal swab and we run it through some chemical processes and some instrument processes in the laboratory to make sure that we find viral DNA and expand it, make millions of copies so that we can say, yes, this person did indeed have coronavirus in their system. The other test is an antibody test, because if you have an infection to something, your body will automatically make antibodies to it. Now, this is very useful information, but it's not exactly useful at the bedside for treatment purposes. Next slide. Okay, this is a nice one little target of viral DNA and making a bunch of copies so that we can say, yes, indeed, because we had these copies, this was definitely there. And then antibody testing works like this. So when you have an infection, your T and B cell lymphocytes produce antibodies, and these antibodies grow and wax and wane depending on how long it's been, so they can show us short-term reaction or long-term memory. And that's important too for things like treatment and public health data. Okay, so when do we use each one? Molecular's got great clinical utility. It's a diagnostic test. Do you have it? Do you not? Basically what that means. Serology testing is more for the fact of tracking, tracing, public health, and possibly offering people treatment utility in the future. You can see here a timeline chart. These are from patients in China. They kept track of when the viral RNA peaked. So this is around the first week. And then you have to wait till 2 weeks to get a proper antibody response. So obviously, not only is this more specific to a virus being inside your system, but it's faster. And this is useful later on. We'll talk about that too. So as far as testing concerns, we're not really doing the best job. I already mentioned supply chain problems and triaging problems, but we also have a high stratified regulatory maze to navigate when we do incorporate testing into our infrastructure. We should be testing up here in the 100 or in the 10,000 per million patient testing range. We're really only operating right at the cutoff of 2,000. That's not enough for us to sort of like move past this pandemic. The magic number is usually, you know, something like having 10% of people test negative if you keep testing everybody is a good benchmark of testing enough people. We're nowhere close to that. This highlights a lot of problems in resource management and hotspots, which are definitely going to become part of social determinants of health. So if you can't rely on testing, most of the people that checked into the poll in the beginning should know about non-pharmaceutical interventions. And everybody who's watching the news, unless you've been living under a rock, which good job for you, you're practicing great social distancing, is practicing staying at home quarantine time. This data from China shows that lockdown actually does affect the caseload and recovery time. I'll give you a second to scan this if you want, but this is real data, you know, laboratory data and the marriage of public health data together. Okay. Thanks.
Great. Before I go ahead and do our questions, we have a very good chat discussion about the acronym for COVID-19. I wanted to confirm COVID-19 starts for coronavirus disease from 2019. Is that correct?
Yes. If I didn't put a link in the slide, I think it should be just the CDC and other people. I mean, yeah.
Okay. We also have a question here for Mr. David. Would the availability of pulse blood oximeters help those with a positive diagnosis avoid ARDs or seek treatment before the disease progresses?
Yeah, absolutely. I think that's a really cheap, simple, and innovative intervention. They're not very expensive on Amazon. Pulse oximeters are really easy to use. You can consult with your, primary physician, of course, first. But if you have symptoms and you're trying to keep away, they'll probably guide you on what number of oxygen saturation your blood would have that would trigger you needing to go see the doctor instead of staying at home.
All right, great. So our first question here is, what is the current discussion regarding antibodies from the infection, herd immunity, and vaccination standpoint?
Great. So the current discussion about antibodies is something I keep foreshadowing here, and it's basically leading to the use of something called convalescent plasma. So antibodies live in our plasma, in our blood, and we can actually take some of that plasma and make sure when it matches compatibility requirements and safety protocols from the FDA and other manufacturing guidelines, actually give it to patients who are the sickest and sort of just give them a little passive boost of antibodies to help them fight the infection. It also informs our studies on vaccination, antibody specificity, and herd immunity is tied to vaccination.
Okay. The next question is, what are the realities of using antigen-based testing since this does not indicate whether the infection is current or past?
Good question, complicated question. So the realities of using serology testing just show us a response. There is an average window to different antibodies showing up at different times. IgM is one of the antibodies you'll see that happens first. It's a big clunky antibody that just kind of like gets thrown out to start the immune response. A little later, our bodies start to produce IgG antibodies, which you'll see, and those act as sort of memory antibodies to fight infections and stimulate us to make more. As a side note, I saw some questions on the side while I was mentioning earlier. A pulse oximeter is something you put on your finger to measure how much oxygen is in your blood, and ARDS is acute respiratory distress syndrome.
Thank you. I was about to ask you that. The last question for this session is a person who had contracted the virus immunized to it?
This is also an interesting question. For the case of something, for example, like Zika, when I was working with Zika prevention teams, I got Zika as an infection, and I can't get it again. That's just the nature of how that virus works. That's a flavivirus. This is a coronavirus. I'm saying that just because it has a different structure. You may develop antibodies to it, but we don't have enough data yet to say that you can be immunized against it. So I'm not too sure, and I don't think any of us have a real answer yet.
Great. Thank you. We are going to move forward.
Great. Okay, so let's talk about what's available right now. As of testing concerns, the FDA releases things called emergency use authorizations, which are sort of shortcuts to approval. And as of this Sunday, there were 41 specific tests for SARS-CoV-2 virus or COVID-19. 37 of them were those molecular tests for DNA, and only four were for antibodies. So you can see where our efforts are going. 16 of those are special laboratory developed testing that you can only do at specific hospitals. EUAs cover all kinds of things, from the way we reuse PPE, personal protective equipment, and the way we reallocate materials for ventilators. Previous emergency use licenses were used for Zika, enterovirus, Ebola, MERS. We actually had a coronavirus plan a few years ago before this pandemic, but we didn't use it. So there's a lot of stuff available right now. Trying to click to the next, there we go. Okay, so how do you get an EUA? Basically, for those working in the federal, local, or governmental sector at any level, you have these top-down decrees of emergency announcements and protocols. If you get a top-down message from Health and Human Services or the director of XYZ that you have a justified pandemic with emergency conditions, the FDA commissioner is given permission to issue these licenses, consulting with different bodies until the emergency is over. The special condition for these emergencies is a lot different from the approval process we use for most testing. Thank you. Okay, so most of you you can see the Food and Drug FDA, that's good. But there's a difference between approved and cleared. Approved means it's going through rigorous proof that something performs at high quality, and the scope of the FDA is very much clinical utility, okay? FDA clearance passes on the merits. You can use it in the laboratory. It's comparable to safety standards, and it goes through more steps. I explained EUA, CLIA, CAP, and other alphabet soup organizations are professional societies that lend themselves to laboratories for regulation purposes through laws like CLIA, or accreditation purposes through inspections like CAP that make sure the scope of a hospital's test is valid and statistically good. Laboratory developed tests are an expected part of laboratory's function, but they have to do a lot of basically biostatistic analysis to prove that a method is good. Next slide, please. I got it. Our roadblocks in testing in the United States had a little bit of a lag time. We wanted to use our own testing models from the CDC before we were able to use the WHO's for reasons I don't know about. But what I do know about is that public health laboratories were the only ones getting this EUA kind of push in the beginning, and then clinical laboratories caught up a little after that. This has been updated since then, so these graphs are just a little off by a month or so, but you can scan here and make sure you see more there. But regulations and testing are really a lot of red tape. At the end of the day, when labs are expected to do this high complexity laboratory developed testing, it has to pass rigorous safety protocols and measures because patients rely on these tests for clinical information. We're celebrating Laboratory Week, as Joanna said in the beginning of this talk, so 70% of all diagnostic information in a patient's chart comes from lab-driven data, and virtually 100% of cancer diagnoses come from lab data. So this is a very critical step in delivering healthcare. Next slide, please. So I said that there's a lot of work that goes into validating, and I won't bore you to death with all this inspection stuff, but if you have something that's already FDA approved, there's kind of a shortcut where you can just verify what the manufacturer wants to do and you're good to go. If it's not FDA approved, meaning you made it in-house, or if it's modified, you have to do a lot more work on the right to prove all those factors. Next slide.
All right, thank you. We're going to go through some quick questions. How do we get testing kits and training for our patient population? Also, where can people go to get an antibody test? And I'm going to add a third one that we got from Rania Mills. And she's asking, does the rapid antibody test look for both IgM and IgG?
Okay. So how do you get testing and where do people go? If you are in any sort of healthcare delivery system, you must consult with your laboratory medicine and pathology professionals. They're the ones that have the contracts with the commercial agencies to get these kits. And they're the ones that can do the work to make sure that it's safe to use. Where do you go for an antibody test? A lot of people are advertising clinics that offer this, and there are so many models that are not exactly FDA approved, so I can't tell you which rapid test tests for what without going through it one by one.
Okay. Are people who are tested positive for COVID-19 given the opportunity to retest after symptoms resolve to see if they are now negative? Do we know how long people are infectious after testing positive for COVID-19?
Good question. So the number one tool right now for testing, the caveat is if you get a test, that's your test, right? If you get positive COVID-19 by molecular, you near 95% had the virus inside your body. They can be negative later, but the viral shedding time has shown in different papers from different journals to be anywhere from 12 to 37 days. So this is why we're taking this 2-week quarantine thing very seriously. More antibody tests will become available in the future, and that's how you can get your secondary testing.
Great. And there's a lot of confusion about the quality of the test available. What are the issues of this test when it comes to false positive, false negative, specificity, sensitivity, and the results waiting time?
Excellent question. Again, I encourage anyone who's interested in this to consult with their laboratory personnel because they're the ones that can navigate this mountain of paperwork. But if you go to the FDA EUA, Emergency Use Authorization website, they have a very transparent list of what tests are available, and all this data about false positive, negative, specificity, sensitivity, etc., are all in their manufacturer inserts.
All right, we have one more question quick from Miguel Angel. What can we do to advocate for expanded testing among vulnerable populations? Is that something you're going to cover?
This is definitely something I'm going to cover. This is a great transition. Thank you for the question.
Great. And before we get to that transition, I'm going to go ahead and launch the last poll for today. So the question is, which of these populations is considered at risk for the current COVID-19 pandemic? All right, I'm going to give a few more seconds. All right, I'm going to close the poll now. And we have 5% responding people with disability, 7% incarcerated, and 89% say that all of the above, people with disability, incarcerated, low-wage workers, and limited English speakers.
Great job, everybody.
With that, I'm going to transition.
Thank you. So there are a lot of vulnerable populations. This is not, it's not exactly an easy topic to cover really quickly, but it can be anyone from someone experiencing homelessness to being in jail to having a disability with mobility or hearing or vision, residents in nursing homes, people of color, people with a language barrier. All you hear about in the media are elderly and those with pre-existing conditions. And that's a little bit of a problem because when you think about social determinants of health, there are a lot of factors that go into health, and in this case, vulnerability. Can you go ahead and switch to the next slide? So I've done a lot of clinical work in New York City, and a lot of the times you'll see patients bump back and forth between inpatient and their homeless shelter. So it's difficult to have a stay-at-home campaign or a social distancing campaign when somebody experiencing homelessness lives in a shelter with 4 to a room or 20 to an eating area. It's very difficult to address that there. And next slide. So we're seeing hotspots now in jails because of close quarters. We want to release patients to create a social distancing environment, but we just can't simply release cases. They have to go through a certain investigational board review to make sure all the logistics are okay. And the pandemic doesn't really care who's committing crimes. It's moving faster than we can operate. So this is becoming a huge problem. Next, thanks. So I mentioned people with disabilities. A lot of people globally, 15% live with some form of disability, whether it's a visible one or an invisible one. And sometimes people need help doing simple things that we take for granted, like washing hands or ordering delivery service. So considering those people is a consideration of how we deliver testing to those people as well. Next slide. There are also myths, on social media that people of color may be differently affected than others because of some sort of genetic resistance or mutation, which are absolutely not true. There was a big viral, to use a good word, social media story that in China, somebody of African descent had a resistance to the coronavirus, which is not true, but that spreads and has to be addressed. Next slide. Currently in New York, this is the hardest hit place in the country as of now. If you're not from New York, there are 5 boroughs as part of the city. Almost 9 million people live here. There are 134 confirmed cases and about 10,000 deaths. We far surpassed 9/11 statistics in this pandemic. Next slide. An interesting way to look at New York will be in these next 2 slides. You can see blue dots and yellow dots representing median household income. Take a minute to look at this slide and notice that the higher incomes are located in Manhattan, high rent, high wage jobs, and the ancillary jobs around New York have lower mean income. Next slide. And you'll see this exactly when you do some case tracking. So positive cases are red and yellow in the top left, and it corresponds roughly to people that work service jobs, people that are behind on rent, people that are affected by disability or people of color or some other socioeconomic determinants of health that we mentioned. Next slide. This is a list of KFF analysis of the number one job, the highest rates of jobs that rely on their employment for insurance. And those wage-dependent jobs that you saw in the Bronx, Queens, and boroughs of Brooklyn and surrounding Manhattan match the jobs that you see here for service work, like waitresses, janitors, carpenters, etc. Next slide. Getting access to care is one thing, but being able to pay for it at the back end is another barrier. This is a high rate of uninsured burden among adults that don't have insurance. Next slide. And you can see here, if we're talking about access and having a job that gives you insurance, trace the Department of Labor statistics from the 60s through the embargoes, through recessions, through Wall Street, through the dot-com crash, through the 2007 housing bubble, and on. We have more unemployment rates than the last like 40, 50 years. So 50% of those people that are dependent on paycheck to paycheck are also dependent on health insurance. And this is shaking the core of a lot of these vulnerable people. Next slide, please. Now, I might argue that there's a new kind of vulnerable population out there. I already brought up a little bit of fake news with that African genetic resistance story, but you're seeing protests all over the country now in Ohio, Michigan, Illinois, the Southeast Florida. People want to go back to their normal life, but they're not really buying into this scientific literacy and problem with this pandemic. I think a job of ours, as all of our jobs in healthcare are addressing different concerns, is to address all kinds of false news, from fake genetic mutations to the 5G story to lab-created viruses somewhere in China. It's all our responsibility to be able to provide reliable, accessible information. Next slide.
Great. We have a few questions. What suggestions do you have about innovative ways to better engage marginalized communities and increase access to testing in areas for communities or populations that face significant barriers?
This is an excellent question, and basically the answer to the question that led us into this section. We have the data that shows us where vulnerable, marginalized communities are. New York is starting to do hotspot testing where high numbers of cases are getting these drive-through stations for specimen collection. I think that's a great idea. But there are also, policy concerns up and down the regulatory ladder that we have to consider moving forward after this pandemic.
Great. What is the best way to assure that we are protected from COVID-19?
Good question. 1, wash your hands. 2, follow guidelines from trusted sources like the CDC that say wear a mask or a face cover when you go outside for essential services. Limit your outside exposure, stay at home, and don't forget to practice compassion for other people that are also going through the same process.
When we have a vaccine for COVID-19, will these communities be affected regarding access to the vaccine as well?
I certainly hope so. Leaving the whole debate about whether people buy into a vaccine program alone, because I won't even go into that. If there's an available vaccine, I certainly hope that will be available for everyone. And I'm going to do my part, as I'm sure most of the audience is going to do their part to fight for that.
Great. How will these vulnerable populations be affected if a state is reopened too early?
This is a great question. We have data from countries like Sweden, I believe, that ended their lockdown too early and cases rose and rose and rose. We have data that people in the 1918 flu pandemic got tired of staying inside and wanted to go outside, and there was a second wave of the same pandemic. So if people can't stay inside, if people are limited by their paycheck or socioeconomic status or other factors, they're going to be doubly vulnerable if states reopen too quickly.
Thank you. We are on the time limit, but if you can just stay with us for another 5 to 10 minutes, we have one more session and then a few questions. And I wanted to invite you, everybody, for more options to ask questions to Dr. Kanakis in a few minutes.
I'll stick around, yeah. All right, so I had you bookmark this earlier. These are all kinds of targets for treatments for the future of how we deal with this pandemic. Some antivirals like remdesivir, some things that affect the virus invading, like you've heard of hydroxychloroquine in the news. All these things are great ideas, but none of these things have been proven yet. Next slide. What is kind of on the buzz of every clinician's radar right now is that convalescent plasma. Good manufacturing and good lab practice guidelines within regulatory guidelines have, a pathway for us to be able to use this to help the sickest patients. Next slide. And right now there are a total of almost 60 randomized clinical trials going on for all those drugs I listed and more. But none of them have enough data or peer review to be able to take any steps forward. So for the medical laboratory science community, its plasma is right now at the top. So when does this end? I mentioned something that, until we get our positive true rates around 10%, we're going to have to keep doing this non-pharmaceutical intervention. That means we have to run about 750,000 tests a day. We don't have that capacity yet. Until we have sustained weeks of no new cases, we still have to practice this sort of stay-at-home solution. You can see here, doing nothing and mitigating a little bit have an effect on not lowering any number of daily cases, but staying home really does work. And as I mentioned earlier, our roles kind of evolved in this pandemic. Everybody from pathologists in the laboratory, clinical workers, public health officials, people doing vaccine work, the essential infrastructure of our country, all the way up to leadership. they now have new roles of how to handle pandemics, disseminate appropriate information, and really guide the public through a very difficult process. But that said, nothing lasts forever. So there is a horizon somewhere. If you live in an urban environment, it can be hard to see it sometimes, but it is there. And the end of this pandemic will come eventually, and then we'll move on. But hopefully we'll learn something and change the policy.
Thank you. Before we do the Q&A, quickly, I wanted to show you some resources available. You will have the copy of this PowerPoint as well, so you can scan them and share. If you have any questions, here's my contact information, jdebo@proceeding.com, or you can send us an email at cbsolutions@proceeding.com. Here's this information from Dr. Kanaki. We're going to give you a quick evaluation, so please take a few minutes to complete it. And tomorrow we'll be having our Coffee House Wednesday at 1 o'clock. Here's the link and the call number. And Dr. Kanaki will be at the meeting, so you can ask him more questions about COVID-19 testing and accessibility. So going back quickly to the Q&A, we have here some questions. Would you recommend antibody testing for CBOs, harm reduction centers, for employees returning to work? Hold on, this is moving. So for employees returning to work, and B, allowing clients to enter our facility upon reopening.
Can you repeat the second half of that? Sorry, I didn't hear you.
Yeah, so would you recommend antibody testing for CBO harm reduction centers for both employees returning to work and or for clients to get into the building?
I see. So we're not at the level where we can deliver that amount of testing. I think it's going to have to happen in the front end. When I say front end, I mean when you have capacity building environments and things where you're trying to grow and address harm, you're going to have people test before they get into that sort of situation. So I don't know if they're going to be allowed to do it at the facilities upon opening because of regulatory issues, but I think testing is going to spread enough so that we can address this before they get there.
Great. I have a few comments. There are necessarily questions, but I wanted to mention some people are talking about the 5G conspiracy or the Microsoft conspiracy. Somebody mentioned that the drive-through testing is assuming that the population has an access to a car, so that also creates another barrier for a lot of the people.
Oh, absolutely.
Jennifer Irvin is asking.
I only mentioned the tip of the iceberg for vulnerable people, but that's a great.
So she's asking, would it be possible to send out the slide deck and the question answer portion of the session for today? Yes, you're going to be getting the recording for the whole session in your emails within the next hour, as well as the materials, including the PowerPoint. Let me see if I have another question for you. You did answer about the rapid antibody tests having both IgM and IgG. Is that correct?
Yes, a lot of them are probably going to have both, but there are so many out there right now that are not FDA approved. I can't give you a blanket answer.
Okay, correct. All right, I don't see any more questions. But remember, tomorrow we're going to be having Dr. Kanaki on our Coffee Wednesdays. So please join us, and you can ask more questions, of course. So Dr. Kanaki, do you want to say anything else?
No, this was a fantastic session. The questions were really, really good. I hope there are more questions like this tomorrow. I'd be happy to answer all of them.
I do have one more question, I'm sorry, from Mr. David. He wanted to, this is about the drive-through. So what alternatives are available that sidestep the barriers of the drive-through? Do you know?
Yeah, there are some places, I know of a few, let's say in Chicago and New York, that are running out of clinics. A lot of people that live in the cities proper don't always have a car. So this is, of course, where you would expect to see them. But some clinics are offering testing for walk-ins, and that would be definitely an answer to that.
All right, great. Thank you very much, everybody. We were so happy to have you here and hope to see some of you tomorrow. And again, if you have any questions, do not hesitate in contacting us. And please do not forget the evaluation. Thank you, Dr. Kaneki.
Thank you.